All right, good morning. We are going to do this morning about respiratory system. And I have given the packages. Number one, this package I'll be going over. Then you'll have question. Any package you're missing when we are taking a break or at the end, ask for it. I put it together. I give everyone. You should have questions here. And you'll have 2 packages with the drugs. So make sure you guys have those packages. And there's 1 package with acidosis and alkalosis. Are we clear? So at the end, whatever you are missing, some of you have done, and maybe you're missing a packet. So when we stop in between, anything you're missing, we will give you. But make sure you have all your packages and we are doing the questions. Without questions and without lab, without procedure, we do not complete the system. So I have given these packages. Anything we are missing, I will give it to you. So I'm going to start with respiratory system. I wrote it down here a few things, and everyone, you will see those are very important, and we will move on with the package. And the first thing is in the package on the first page is sputum specimen collection. So I will talk about, first is the procedure. It's a respiratory system, so we got to collect the sputum specimen. And so everyone should know, what is the best time you collect the sputum specimen? What is the best time? In the morning. And so remember, we are collecting the specimen. And how can you collect the specimen? There are 2 ways you can collect. Either patient can expectorate, and if patient cannot expectorate, and then you have to suction. And if patient has a tracheostomy, you're still going to suction. So we can suction the patient can expectorate. So let's see on the page number 1 is expectoration word you have on the first line. So you are asking patient to expectorate. That's a good wording. And tracheal suction. So you're going to suction. So either 2 ways you're collecting the specimen. In the procedure, the best time, highlight the word early morning. That's in the first line. And what can you tell the patient to do before you collect? You can rinse the mouth, but only with water. No mouthwash. So if patient is rinsing the mouth, you can use the water. And how much really do we need the specimen for collection? How much specimen do we really need it? It's about 15 ml. You don't need to fill up the whole cup. At least 15 to 20 ml. 15 ml we have, that's good. Now what happened if patient spit it? Word. And you see patient spitted the sputum, and they're saying, and frothy, spitting and frothy. It doesn't mean that's coming from the lungs. Are we clear? So what do you do? If that wording is there, then you discard that and you collect the specimen. And what would you teach patient before you collect the specimen? You have in the next line is underline the word breathing, deep breathing. So what do you tell the patient? Deep breathing. If in your questions you have assist patient or help patient to take a 3 or 4 deep breath, that's good. Second wording is good is what? Coughing. Have the patient cough, and I want you to add there expectorate. And what do you tell the patient to expectorate? Is it's coming from the lungs. Now, if you are collecting before patient is starting antibiotic, always remember you got to collect the specimen before you start antibiotic. Why? Why do we need to do that? Because you want to know the exact culture. A patient already had antibiotic and you don't know if that's going to be resistant. So before you start antibiotic, you must collect the sputum specimen. And immediately you send it to the lab. If you're not sending it to the lab, then what do? You can keep it cold, keep it in the fridge, and also remember you have biohazards bag. Whatever you're sending to the lab, you got to put in a biohazards bag, and you got to send the lab slip. So everyone is okay? In sputum specimen, first thing is remember early morning. What would you teaching in your questions are, you tell the patient to what? Take a deep breath, cough, expectorate, and do not contaminate. How would you contaminate? We have a container. If you're touching inside the container, it's going to be contaminated. So you don't want to contaminate it because you want to do the culture before we are going to do the antibiotic. So everyone is okay, collection of specimen. Number 2, very important procedure is bronchoscopy. Patient is going for bronchoscopy. It's invasive procedure. We do need the consent. And what are they looking? They're putting a scope through the mouth. And they're looking, you have larynx, trachea, and bronchi. So bronchoscopy procedure, you do need a consent. And very important, that patient has to be NPO. So remember, they are going to prevent from aspiration. So what do? They must be NPO. Now, if patient has dentures, that should be removed. And always make sure your consents are signed. Now we'll move on to the next page, and that is post-op care. So very important is NPO, bronchoscopy, because they're going through the mouth. You must have your patient NPO. Next is post-op care. What do you do after patient comes back? Is important wording is line 3, is gag reflex. So post-op, when patient is back, post-op care, gag reflex is important. What is the meaning gag reflex? Before you give any fluids, make sure patient is okay and they have the gag reflex. Next line, underline the word perforation. So gag reflex and perforation. These are important. Before procedure, we must remember NPO. After procedure, gag reflex and perforation. What is the meaning perforation? Bleeding. So what would happen patient? Maybe they're having a vital sign changes. If patient is running fever, sign of infection. It's a procedure. Could be a fever. Could be a word pneumothorax. What is a pneumothorax in the last line? You have in post-op care. What is pneumothorax means? Collapse of the lung. Lung can be collapsed, and that can be, you monitor the breathing. Any breathing problem, and if patient has fever and any vital sign changes, you must notify the physician. So everyone is okay about bronchoscopy, and 2 word is everyone must remember is NPO before, after the procedure, the gag reflex and perforation. Now we will move on, pulmonary angiography. What is pulmonary angiography? They're going to insert the catheter, and from where? Underline the word antecubital and femoral. Where is antecubital? It's right here. This is antecubital. We always use this word antecubital because when you're taking your blood pressure, we are using this word antecubital. So they can go from here, they can go from the groin, and that is called the femoral line. Now what would you do pre-op care? Consent and correct the spelling, line 2, assess for allergy. So make sure you write the word for allergy. NPO. What would you tell the patient when they're putting angiography? Word is they're using the dye. So they're going to use the dye, you're checking for allergy, but what would patient feel when you're putting the allergy? And what does it say here? Is they may feel urge to cough, underline, very important, flushing, very important, salty taste. All your word, whenever we are using allergies with iodine, patient would feel flushed feeling and salty taste. And they do ask, what does the patient feel when you're inserting the dye? So that is in your teaching question. Post-op care. What do you monitor after the procedure? If they have used antecubital right here, you're not going to use for blood pressure. Because why? When you're putting a blood pressure and you're checking the blood pressure, they can bleed here. So in antecubital, if they used it, don't use the blood pressure on that side. That says in the first line. Then you will go, the last one is very important, is monitor for bleeding. So everyone, pulmonary angiography word is that they're looking into pulmonary artery. And what are they injecting here? Dye. What are we asking patient for? Allergies. And what do you tell the patient when you're inserting iodine? That they feel salty taste and flushed feeling. And after the procedure, we can always give them the fluid. Why? It helps them to take out the iodine. So everyone is all right? Pulmonary angiography. Take those. Now, pulmonary angiography, word is we are checking from where? Antecubital and femoral line. And after the procedure, what are we monitoring here? Is the bleeding. Next page, we will move on. Very important word, I wrote it here. Bronchoscopy, we should know. Thoracentesis, we should know. What is thora means? Thoracic. We are talking about respiratory. What is this part? Chest. And what is this word is called? Thoracic cavity. Are we clear? So where are we inserting needle here in thoracentesis? We are inserting the needle in where? In thoracic cavity. And where? I want you to highlight the word pleural space. Where is the pleural space? Is around the lungs. So what do we have? The lungs. And lungs are covered by what? 2 layers. And in between the layers, they're injecting the needle and they're going to aspirate the fluid. So everyone is okay? Is thoracentesis where we are inserting the needle around the lungs. And what space is called? In your notes, you have pleural space. Make sure everyone knows the pleural space. And that is very important wording because you are inserting between the layers around the lung. And what are we taking out? The fluid. Now, a lot of time can be patient has a lot of fluid around the lungs, maybe a diagnostic purpose, maybe to remove the fluid. Now, what is it important here when patient is going for thoracentesis is, number 1, consent. I already asked you to highlight the word pleural space, so we must know where are we inserting the needle in the pleural space, and what do we need? Consent. What position are you going to put? So let's move on to the position, and position is very important. What position do you think your patient should be when you're inserting the needle? Sitting upright. Everyone is okay? Now, when you're sitting upright, it's easy to draw the fluid. So sitting upright is the best. But there are patients who can sit upright. Then what do? You can put them in other unaffected side. So there are 2 wording. Highlight those words, upright position, unaffected side. So if they're going to insert the needle on the right side of the lung, the patient can turn on the left side. So that is important, the positioning. So everyone should know the position. And last word, if you will highlight, is what do you instruct? Before patient is scheduled, very important. Patient is going for thoracentesis, pre-op teaching. And what is in pre-op teaching is that do not cough, do not move. Why? Because what will happen is puncture the lungs. And what happens if your patient has, in your question, or you're in your real life, you're working and patient is scheduled for thoracentesis and patient has a chronic cough? What would you do if you're sending your patient for thoracentesis? Give the cough syrup. Give the medication. Why? You don't want the patient to cough because if you're coughing, you're moving, and if you're moving, what can happen? The risk is puncture the lungs. So very important teaching question. Everyone should know. 2, 3 wording here in thoracentesis. What is in thoracentesis we need to know is number 1, where are we inserting the needle in pleural space? What are you going to teach the patient? Not to move, not to cough. What do you give before the procedure? If patient is coughing, give them cough syrup. But if they're saying patient started acute cough And fever, you must notify because that is a new problem and may not be the procedure would be done. So you need to contact the physician or your supervisor and make sure we report it. After procedure, what do? First thing is I want you to write down the position. So add that, it's not written. So I want you to add post-op procedure, keep the patient unaffected side. That means they can turn them on the back or turn them on what side? Unaffected side. If they've gone on the right side, they can lay on the left side so they can breathe better and the pain. And what do you monitor? The vital sign. What do you monitor after the procedure? Second line, respiratory status. Patient is bleeding, you need to notify. In the last line, it can lead to complication. Now, if you can't remember, that's okay, but it can lead to pneumothorax. Pneumothorax is collapse. Patient is having abnormal breathing. You got to notify. Pulmonary edema. Patients start having, what is the sign of pulmonary edema? Pink, frothy sputum. Pulmonary embolism, breathing problem. So any questions, patient has a breathing problem, you're going to notify about the patient discomfort. Fever, you need to notify. So everyone is okay, thoracentesis, where are we inserting the needle? In pleural space. What do you teach patient before procedure? Not to cough. Everyone should know the position. What position I said? Upright or turn them on unaffected side. If patient come back, same position after procedure, unaffected side, make sure patient has no fever, breathing sign, vital sign, you monitor and monitor the side they have done for any leakage or bleeding. So those are your thoracentesis procedure. The next is pulmonary function, yes.
What is crepitus again?
Crepitus is rubbing sound. So when you're feeling like rubbing, friction, that's a crepitus. Her question is, what is crepitus? Because you do have the word crepitus. It's like friction or rubbing sound that you need to notify. Pulmonary function test. What is a pulmonary function test? You are assessing the lungs. What are we assessing here? The lungs. And underline the word gas exchange. What is a gas exchange? What are we exchanging in our lungs? Is oxygen and CO2. What are we breathing in? What do we breathe in? Oxygen. What do we take it out? Carbon dioxide. So how does it happen through our lungs? So what we are assessing here, the pulmonary function test. What is the word called when we are breathing in? What is the word is for breathing in? Inhalation or inspiration. What is the word when we are breathing out? Expiration. Everyone should know inspiration, expiration. Those two words are important. And oxygen, carbon dioxide, these are the gas we are exchanging. And lungs are very important to maintain your pH and your acidosis and alkalosis. We'll be talking a little later, but for now, pulmonary function. We got to see how the lungs are functioning. And what are we checking in functioning of the lungs are, underline the word gas exchange. What is the meaning gas exchange is oxygen and carbon dioxide. And also it helps us to know what? Acid balance, the pH word. Acid balance is how much is oxygen, how much is carbon dioxide. What do you do is important if you're going to assess the lungs are pre-op care. What do you hold before patient is going for this test? Underline the word bronchodilator. What is a bronchodilator? The medication patient is taking and opening up their lungs. So you want to see how the lungs are without the medication. Are we clear? So patient is scheduled, always we check what drug need to be hold. So you may have to hold bronchodilator. Tell the patient in the last line on this page, smoking. They shouldn't be smoking and eating not too heavy meal before the test, 4 to 6 hours before the test. So everyone is okay. Pulmonary function test is you're doing to look at the lungs, how they're exchanging oxygen and carbon dioxide. And what do you hold here? Very important to wording. There may be one question, patient is scheduled for pulmonary function test, and they're asking you, what would you do? Your answer would be to hold the medication, and for smoking maybe, and light clothing, so that would be on your pre-op care. Next page, we will move on, and it says, after patient come back, it's okay, they can resume normal activity, they can eat normal diet, and you can continue back with their medication. But before the test is important word is to hold the bronchodilator. Lung biopsy. When we are going for biopsy, biopsy means, underline the word, in the first line, they're taking a tissue. What is biopsy? Is tissue. And also they use the word by culture or cytological exam. So second word is for biopsy is cytological exam. What do you do before biopsy? Patient is going to go NPO. Consent is always important. And after the procedure is make sure you keep the dressing on and the biopsy site. And what do you monitor? Highlight the word bleeding. All your biopsy, you got to monitor bleeding and add there infection. And so second word, I want you to add there bleeding and infection. Any biopsy, they can bleed and you want to prevent them from infection. The last line, any respiratory distress, any vital sign changes, you got to notify the physician. The next word is, on the test is ventilation and perfusion lung scan. When they're doing the scan, they're using radionuclide. So underline that word. And also they're injecting and the patency of the pulmonary airway. So they're checking the lungs, they're checking ventilation, perfusion. A scan means they're using radionuclide. Procedure is pre-op, is consent. Second word is allergies. And third word is remove any metals or jewelry. Now the next page, we will move on. After the procedure, what do? Is monitor any reaction, and it will take about 8 hours by the time the radionuclide is out of the system. Now I will move on skin testing. What is the skin testing is? Where do we use the skin testing? In giving your PPD. Which patient do we give for PPD? To know what? For TB exposure. So skin testing is done for what? Underline the word hypersensitivity. Now we normally use the word allergy, but a lot of questions you may not have the allergy. So when we are reading the word is you're doing PPD or skin testing, what are you checking? Allergies, and what is the other word for allergy? Hypersensitivity. Now what do you do for the procedure? Number one is a skin site. You want to do where the less hair. And what is the best part of the less hair is in the third line, inner surface. Inner surface of the arm has less hair. Outer surface, a lot of people has more hair. Now again, if person is right-handed, you can go on the left. Someone is left-handed, you can go on the right side. Any arm can be chosen. You do have here the left arm, but a lot of people are left-handed, you can go for the right arm. So non-dominating hand, you can use it. And what do is you circle after you injecting. But how do we inject your skin testing or PPD? It's called intradermal. I want you to write down intradermal. And when you're injecting in intradermal is, what is the angle of your needles are 10 to 15 degree. Very good, you guys are aware. So remember, skin testing is done intradermal. And you only give very small amount of medication, maybe 0.1, because what are we checking here? Allergies. You don't want to inject a lot of medication, So you are only injecting very small amount. And after you inject, then what do? It says circulate. So you got to circle the area so you know where you gave that intradermal testing. Are you going to document in your med book? Yes. In MAR, you're going to write it down when you're working and you're giving to your patient. We got to make a circle, write it down, what arm you gave, what time you gave. And the next line, when are you, and what do you teach patient? And your question would be, and it says, because what happened if you are allergies with that? You feel a scratching. And what does the scratch can cause? Infection. I want you to highlight the word, teach the patient before they're going home and after you give them not to scratch. Why? Because scratching leads to infection. Underline that word, and abscess. So you want to prevent from infection. So that goes in your teaching to your patient after you give it. But when are you going to read it? We need to correct here. It says 24-hour, cross it out. We should read it 48 to 72 hours. So when do we read after you give any allergies or your PPD? 48 to 72 hours. Now what do you monitor after that time is if there is a redness. If there is, how far is the redness is there? And how much is there swelling, the red, and how many millimeters? So the last word, mm. How do you write? 0.5 mm or 5 mm, 6 mm, 7 or 8, because you want to look how big the size is. So that is on your skin testing. But because we are doing it and we are looking allergies, always remember when patient can get allergies, what happened to them? Anaphylactic reaction. So allergies, you got to give very small amount intradermal. Everyone should know, and your reading for your PPD is 48 to 72 hours. Pulse oximetry. I will move on. Pulse oximetry, we all do pulse oximetry. And what are we checking here? Oxygen saturation. Underline SaO2 and oxygen saturation. What is oxygen saturation is, I want you to add there in the tissue. It's not in the blood. When we are doing in a blood, then what do we do here is ABG. I want you to write down the word ABG. What is ABG? Arterial blood gases. So remember, when we are doing ABG, that's the blood test. And when we are doing pulse oximetry, we are placing and we are checking oxygen saturation. Normal should be 96 to 100. Now we can highlight, we all know we can check on the finger, we can check on the toes, earlobes, and nose. And also it says forehead, but the common we all use are the finger. And next page, I want you, very important, is extremity. And it says, do not select extremity if it has impediment or blood flow is poor. A patient had a stroke and you have a left arm very weak. You do not choose them because they already had a poor circulation. Everyone is okay that? And also SaO2, 85% compromise. And O2 is 70% would be life-threatening. So life-threatening means we got to do something. So in respiratory system, we all know we have to check O2 saturation. Now before I move in, I want you to know ABG. What is ABG? Are here arterial blood gases. And you're looking, what are we looking in ABG? Oxygen and CO2 level. And what test do you do before you do ABG? I want you, everyone to add there, is Allen test. Everyone is okay, what do you do? Allen test. Now, we must know, because we are working and we have a lot of patients with that Allen test. And what are you looking in Allen test is circulation. Are we clear? What is the circulation we are checking here? Is your radial and ulnar artery. So remember, radial and ulnar. So what they do, they squeeze their arms and then they're looking if the circulation is good, then they will draw the blood. I want to write down few things for blood tests, which you don't have in the package, is because I know everyone should know. An Allen test, when you draw the blood, how do you keep the blood? Is in ice. So when you're sending it to the lab, it should go in ice. So everyone write down before ABG, you must know you're checking what? Allen test. How do you keep the blood sample in the ice? What kind of tubes you're going to use it to keep the blood, which has heparin? So write down heparin tube. They're called hep tube, and those tubes are containing heparin. And also, what do you write on your lab slip? We are nurses, very important. You're sending the lab slip. Now remember, your patient, you're sending it to the lab. A lot of your patients are already using oxygen, and you're drawing that blood. Now you've got to write on the lab slip, patient is on oxygen. Are we clear? And how many liter oxygen? If a patient is taking 3 liter, you've got to address on the lab slip. Patient is on 3 liter of oxygen. If patient is not taking any oxygen, we call room air. We are breathing right now in a room air. So we got to add that in the slip, because when the labs are going to read and it looks a good oxygen because patient is taking, that will not give us a good lab result. Everyone is all right? So what is ABG? Arterial blood gases. What do you do after you draw the blood? Apply the pressure, because they can bleed. So everyone should know applying pressure. Number 2, keep them in ice. Number 3, send it to the lab with the lab slip, and make sure the lab slip has, with oxygen, how many liter or patient is breathing in room air. Everyone is all right? We talked about is the blood and oxygen and pulse oximetry. And very important that patients are breathing and you're checking how their oxygen saturation are. I'm going to talk about suction. Let's move on suction, whether it's a nasal suction, throat suction, or you're doing tracheostomy suction. Is number 1 is aseptic technique. Is important, the word is aseptic. And all that means is sterile. You have tracheostomy, you're going in, you should have aseptic. That means your catheters are sterile and sterile gloves. Very important word, it says second line, hyperoxygenate. So when they're giving you a question, or we are going to do a suction, before we suction a patient, make sure they have enough oxygen. And the question, or before you do your suction, what do we do here? Make sure the wording is what? Hyperoxygenate. And write down the second word. Sometimes they didn't give hyperoxygenate, and they had, before you suction, we use the word pre-oxygenate. So write down the word pre-oxygenate. Pre means before. So remember the word pre. Whenever we are using the word pre means before. So before you suction, what do? Your patient must be oxygenated, pre-oxygenated or hyperoxygenated. Then next line, lubricate. Before you insert the catheter, you must lubricate. How would you lubricate? You are not using KY jelly. Underline the word normal saline or water-soluble lubricant. So what are we using here? Normal saline. Mostly we have normal saline because we use for suction. So if you don't have water-soluble lubricant, that's okay. But you're not taking is your KY jellies. Go on water-soluble. And what do we use? The best is your normal saline. And how far you can insert in tracheal is about 4 inches. And you can go through the nose, and if you're going nasal tracheal suction, you're going through the nose. How far do you go? Patients start coughing, induce cough reflex. Highlight that word. And then you apply suction. How long can you apply suction when you're suctioning your patient? The max we can go 5 to 15 seconds. 5 to 15 seconds. Everyone is okay, 5 to 15, no more than 15. You can go less, but never go more than 15 seconds. And what happened when you suction that long to the patient? What happened? What do you do when we are suctioning? What does it cause? Hypoxia, lack of oxygen. We are closing the airway. So what are you monitoring during suction? Hypoxia word. So write down the word. Any question? What can happen to your patient when you're suctioning is hypoxia, lack of oxygen. So we have to be careful, don't go too long, because what can happen, we are cutting down the oxygen. So remember, is how long do we suction? 5 to 15, and what is effect of suctioning is hypoxia, lack of oxygen. Next is, what do you do when you're in, and when are you really suctioning your patient? When are you really suctioning? We are putting in the catheter. Are you suctioning when you are putting in the catheter, or you are suctioning when you are taking out the catheter? When we are taking out the catheter. Remember, we are not closing. When we close the suction with the finger, that is the time we are suctioning. So we are taking a catheter in, and once it's in, and you start rotating word. Write down the word, it has there, rotate the catheter, and then you apply suction, and you are applying suction when you are withdrawing the catheter. So when do we suction? In your questions are, when you are withdrawing the catheter. How do you lubricate the catheter? With normal saline. How far do we suction here? How long do we suction? 5 to 15 seconds. What is the effect of suction is hypoxia. Now, I will repeat another thing. Maybe you have a question, or when you're working with your patient. You did suction for 10 seconds, and you still see patient has a lot of phlegm and is coming out. What are you going to do? You're going to suction again. Are we going to clear? So what do we do when you suction again? And I said pre-oxygenate. Now what do we do? Re-oxygenate word. So remember two wording. Whenever they're asking you, before you suction next time, what do you do? Re-oxygenate. So is wording. Sometimes the wording is hyperoxygenate. Sometimes what do you do before you suction? Pre-oxygenate. When you are going to suction again, what do we do? Re-oxygenate. Are we clear? So pre-oxygenate, re-oxygenate is good, and we are suctioning our patient. I want to go a little bit on tracheostomy. If you have tracheostomy, what tube are you removing? You don't have it there, you can add there, because we must know something about tracheostomy. And if you have tracheostomy, what do we take out? The cannula. We all should know what cannula. The tracheostomy tube is out here, and we have the tie which goes in the back, and that is the outer cannula. What cannula do we take it out when we are cleaning is only inner cannula. So make sure we all know inner cannula. And what do you do when you remove the cannula, and how do you wash the cannula and clean the cannula? How do you wash it? Is good with what? Hydrogen peroxide. Good. So how do we clean the catheter here? Anytime. Because what happened? They have a lot of phlegm. And what happened here? They're not going to be able to wash. It won't come clearly with normal saline. So you're using normal saline, but the phlegm around the tubing will not be clean. So the best is you can wash it with hydrogen peroxide. So everyone should know you're washing it with hydrogen peroxide. Now what do you do when you're removing the tie? When you're removing or you're changing the tie, what do you do? Put the new tie before you are removing the old one. That's also in your questions, and that can be also asked, what do you do? You remove the tie, and you're removing the tie, old one, but before you remove, you put the new tie, okay? Now, what do you keep in the room if you have tracheostomy patient? What do we keep in the room? What do we keep in the... Another trach, yes. Obturator. You guys remember the word obturator. All right, everyone, what do we keep in the room? The word is called obturator. And somebody said the tracheostomy tube. Yes, we should keep the tracheostomy tube. But what size of tracheostomy tube are you going to keep? Same size. Very good. You guys are very good. You know, we are keeping the same size tracheostomy tube. And what are you keeping in the room? Obturator. Because once it comes out, what is the big priority we have? To keep it open. And that's why you need obturator. So let me repeat it, few things here, and those who just came in or those who were here, is just remember in suctioning, how far do we suction, how long do we suction? 5 to 15 seconds. And what do you do in suctioning is lubricate the catheter. How do you lubricate the catheter? With normal saline. When do we suction our patients? When we are taking out the catheter during not inserting, and rotate the catheter and suction your patient. 2-3 wording is important: hyperoxygenate word, pre-oxygenate word, or reoxygenate word. So those are important in suction. Now I will move on incentive spirometer, the next word. And I wrote it down, some of the word, very good, that we must know incentive spirometer, because we are living in prevention. And what do we do to teach our patient to use incentive spirometer? Now remember, they're not going to say what is incentive spirometer. Our questions are attached that we are critically thinking about our patients. And which patients are you going to use incentive spirometer? Which patients are we going to use for incentive spirometer? After surgery. Very good. After surgery. And which are the other patients you will use it? Those who are laying in a bed for longer time, immobility. After surgery, number 1. Patient is going to stay in a bed for long time. And lot of time patients who have rib fracture. Because why? They have a lot of pain and they will not breathe. Maybe in pancreatitis, GI system patient. Why? Because they have a lot of pain. And when you have pain, you don't want to breathe hard. So what happened? We develop pneumonia. So you are using incentive spirometer to prevent patient from pneumonia. Pneumonia is one of the complications we have a lot of our patients, and that is why what is pneumonia is called, I will be talking a little later, is nosocomial infection. What is the meaning nosocomial infection? It started in the hospital. They didn't come in, they came for fracture, but patient had what? Pneumonia. So we are nurses and we need to prevent getting patients from pneumonia. So we got to learn. Critical thinking is patient is laying in a bed, patient has a lot of pain, and we got to teach them to take a deep breathing. Very good is to take deep breathing and turning, but yes, incentive spirometer. Now what do we use in incentive spirometer? You are giving a spirometer, you must have seen in the hospital when they come back after surgery, they give them, and you have to teach them how to breathe in. So what do we do here? Number 1, position. Sitting upright. Position is sitting upright. And number 2, place in the mouthpiece, they're keeping in the mouth. But before we go in there, after upright position, I want you to write down the word exhale. What do they do before you start breathing in? Exhale. So add there, exhale. And then you will say, is the device to put in the mouth. And what do you teach is, third line, inhale slowly. All your teaching, when we are breathing in, slowly is the best way. You breathe fast is not going to help them to expand the lungs. So what do we do is inhale slowly. And they have a flow meter and a flow rate, and it goes up to 600 to 900. So that's, what do you teach patient? Slowly breathing in, and there is a flow rate on the side that you can see in. Those little bulbs, they're moving up. And if they're not moving up, what does it mean? The lungs are not expanding. So if it goes up 600 to 900, that means the patient is doing good and the lungs are expanding. Then what do you tell them? To hold for 5 seconds and then exhale all throughout the system. Remember the pursed lip breathing, which is in the lowest, I wrote it down, but all you're teaching are what? Pursed lip breathing. And why? To prevent them getting tired and also to breathe out easily. So what kind of breathing we are doing? Pursed lip breathing. Now the last line, it says repeat this. Correct the spelling is procedure. How many times the patient can repeat the procedure? 10 times every hour. So every hour they should do it 10 times. Everyone is okay? So what do we teach here? Breathe in slowly and then hold it and exhale or take it out. How? By pursed lip breathing. So incentive spirometer is we are using why? To prevent patient from getting pneumonia and preventing the complications. So we all should know your suction, sputum specimen, thoracosynthesis, we talked about that. And the next word is chest physiotherapy. Now everyone is chest physiotherapy, incentive spirometer. Every time we are dealing with respiratory system, we must know. What is a chest physiotherapy? Is when we are giving exercise, when we are going on the chest and we are giving exercise to the chest. To what is the purpose is here? To loosen up the secretion. Now I want you to highlight the word. What is the best time CPT should be done? Underline the word in the morning. If you haven't done in the morning, the best thing is to do in the morning. And if you're doing more, should be 1 hour before or 2 to 3 hours after meal. So when do we do CPT? Morning, early morning, 1 hour before or 2 to 3 hours after meal. Anytime patient complains pain, you got to stop the procedure. Next page, we will move on. If patient has a tube feeder, we check residual. Underline the word residual. And what is the residual when you know more food is there? 100 or more than 100 ml. If it is the residual is 100 or more than 100, then you are going to hold it. What else administered? Next thing, very important, before you are going to do CPT or postural drainage, what do we give? Before the procedure, underline the word bronchodilator. You want to remove the secretion, but what do we want to open here? The lungs. You want to open the air passages. So what do we give here? Bronchodilator before procedure. Then you go, the word is CPT is what? Percussion. Highlight the word percussion. Second word is vibration. So what is CPT? We are doing what? We are doing percussion and vibration. So these are the two words, percussion and vibration. Stop the procedure if patient has cyanosis word. What is cyanosis means? What is cyanosis? Blue color, lack of oxygen. And you underline the word cyanosis and repeat until in the next line is no longer expectorating the mucus. So we can continue if patient is taking out until that. And after the procedure is very important all throughout your respiratory mouth care. Why? When you take out this phlegm and it's very foul smelling, what happened? Appetite. So any question, it looks very simple. What is it so important when you do your sputum collection? Mouth care. When you give your treatment, what do? Mouth care. So mouth care, we are nurses, very important on our patients to do it. So after the procedure, mouth care. Now I want to have you highlight the word in the last 3 lines. You have percussion word, vibration word, and postural drainage. So what are we doing here? We are giving percussion, vibration. After CPT, they turn the patient in postural drainage, positioning. And why do they put the positioning? and underline, next line, performed over the thorax to loosen up the secretion in the affected area. What area do we put the patient in? Affected area. Let me repeat here, is we have is your incentive spirometer, and we talked about chest physiotherapy. What is the meaning, chest physiotherapy? That we are giving our what? Percussion, vibration, and postural drainage. Before you give CPT, what do we give? What do we give before CPT? Bronchodilator. After you finish the procedure, what do? Mouth care. Everyone is all right? So we all highlighted the word. And next, I will move on, breathing technique. And what is a breathing technique? Why do we want patient to use a proper technique in breathing? What is the purpose is here? Now, what happens when you're having a hard time to breathe? What do? We use a lot of our muscles. Are we clear? And what happens when you're using your muscles? You're getting exhausted. So it's important, how do we teach a patient for breathing? Number one, underline the word pursed lip breathing. So what is the best is here? Pursed lip and diaphragmatic breathing. You don't want to use the chest muscles for breathing. So what technique would you teach anytime they ask you, how do you teach a patient for breathing? Pursed lip breathing and diaphragmatic breathing. And what is that? Next page, we'll move on. It says here, inhale slowly. How do you inhale? Slowly and through the nose. And you keep the hand over the abdomen, and you can see the chest is expanding. Exhale 3 times longer by blowing through the pursed lip. So very important 2 words here. Inhale through the nose. Exhale through the mouth by blowing through the pursed lip breathing. Inhale through the nose. Exhale through the mouth, and very much blowing and slowly. So that is your teaching for your patient for the breathing technique. Now they use also huff, cough, coughing. When they're coughing, the coughing technique. Now you do have a lot of wording here, but what is the main purpose you want to teach your patient how to cough and how to breathe? The first line, to conserve energy. You don't want the patient to use a lot of energy for coughing and breathing, and reducing fatigue. You don't want them to get tired. And also to mobilization of secretion. You want the secretion to move. Now in the third line, deep breathing through the pursed lip and diaphragmatic breathing. And now is important word, leaning forward. How do they do? Lean forward, and the client should cough 3 to 4 times during exhalation. That is your half coughing technique. So underline the word. How do we teach them cough? During exhalation. Are we clear? So leaning forward and cough 3 to 4 times during exhalation. Now we are nurses, and we must know how to teach patients to use incentive spirometer, how to do cough technique, and CPT. Questions are there. Postural drainage. Everyone is okay? CPT, postural drainage, bronchodilator. When do we give bronchodilator? Before you're going to do what? CPT and postural drainage. After the procedure, what do we do? Oral hygiene. Make sure we all know oral hygiene is important. Now I'm going to move on oxygen therapy. When we are talking about oxygen therapy, is we do give oxygen by nasal, by cannula you're giving by mask. So very important, we have here oxygen by nasal cannula. When you're giving nasal cannula and it says 6 liter, you can give up till 5 and 6 liter, but how much patient is getting oxygen through nasal cannula? Underline the word 44%. They're not getting enough oxygen. So what happens if your patient has pulmonary embolism, a patient need more oxygen, you will not use cannula. So cannula is only good when you're giving less oxygen and patient is okay. So you can go 5 liter, 6 liter, and 2 liter, 3 liter, but how much oxygen are we giving by nasal cannula is only 44%. Now, next thing is very important when we are giving through nose, because oxygen is very dry. And when we are giving through the nose, what happens? It dries up the nasal passage. So your questions are going to be, and as a nurses, very important, we need to know the word humidifier. So it says in intervention, humidifier. And when you're using humidifier, why? The third line, highlight the word dryness. Why do we use humidifier? You have seen those little bottle, and those bottle has what? Is the water there, sterile water, and the oxygen is flowing through that sterile water. And why do we use that bottle? Are to prevent dryness in the nose. But what would be the big problem with this bottle? What is the problem with these bottles? Anybody? What is the problem with the bottle? Do we need to change them? What will cause here? Infection. Very important, these bottles, and we have big and strict regulation. And what are those regulations are? That when we are putting this bottle, we must put the date on. And how long can you keep? Now what happened, you had a patient who needed a PRN. Think about nursing home patients, home care patients are, and in acute hospital they're coming and they're moving faster. The bottle may not be staying too long. But what happened when you have a nursing home patient who is there in room for a long time, and you put that bottle and oxygen was not used for 2 months, and the bottle is still hanging there, and after long time patient need oxygen, we never change the bottle and we start using that, lead to a lot of infection. So it's very important is when we all are nurses, wherever we are working, make sure check the policy. We have to write a policy, how far and how long are you keeping that bottle? Maybe 5 days, maybe 7 days. But if you have about 10 patients with oxygen and you have humidifier, and what do? You change them. Now you guys might have seen those little concentrator, and you have to make sure you got to change those bottles and clean the filter in the back with the oxygen. So remember, humidifier bottle, questions are, number 1 is put the date on. Number 2, why we are using to prevent is what? Dryness. And what is our responsibility as a nurse? That we must put the date on. If it's staying too long, you must change it, because you don't want to leave it on for longer time because it's going to cause infection. So every nursing home, every places, they have a policy and they must be changed every 5 days or every 6 days. Everyone is okay? So what can this bottle can cause? Infection. They must be changed. Now let's go on simple face mask. You're giving about 8 liter oxygen. And how much oxygen patient is getting? Only up to 60%. So highlight that word, 55 to 60%, still not 100%. The third one, you have partial rebreather. You're getting about 90%. Partial rebreather, you're using your rebreathing back is from the same, and that is about 90% on how much oxygen you're giving, up to 15 liter, but you are still not 100%. The next one is your non-rebreather mask. So when we are asking, how do you give 100% your oxygen when your patient has pulmonary embolism or patient cannot breathe in, is non-rebreather mask. Underline the word, second line, more than 90%. That means you can get 100% with non-rebreather mask. Everyone is okay? Which is the best when you need more oxygen? Non-rebreather. When you're giving lesser oxygen for your cannula, you're getting lesser oxygen, like 44%. Venturi mask also is used. Why? Now, it has a adapter. Number 1 is Venturi mask has adapter, and then you will go on the second line, it has some holes. and a different size. And what they do, on the third line it says, allow only a specific amount of, correct here, oxygen desired, whatever, 24 to 55%. So it can mix it with the other air, and that is you can adjust it with venturi mask. But for simple reason, we all should know nasal cannula, you can give lesser, and the 100% you will go for non-deep breather mask. I'm going to go on ventilator question. Is you do have ventilators, and ventilators in the high pressure, and it says the low pressure ventilator alarms are on. So what is high pressure alarm means? There are secretion. So underline the word. Maybe the patient alarm goes on, there's a lot of secretion. That means we may have to suction. Maybe patient is having wheezing problem, bronchospasm, or maybe you have third line, endotracheal tube is misplaced. The endotracheal tube, maybe it moved away, maybe there's a kink, there may be obstruction. And patients start, what is the symptom you will see when the alarm is on? Patient is coughing, gagging, and also biting. And patient is very anxious because it's not working. So what do? You fix it. Whatever, if the tube is kink, check for the kink, fix the kink. If patient needs to suction, if the endotracheal tube is off, you got to fix it. So the meaning is high pressure alarm, we can fix it whatever the patient has problem. If there's a kink, if there's an endotracheal tube, if there's a lot of secretion, you suction it. What is a low pressure alarm on is, that means we cannot fix. Why? There's a disconnection or there is a leakage in the ventilator. Then what do we do here? Patient would stop breathing. What do we do here? We got to change the ventilator. And what do we may have to do? Put the ambu back and then you start moving the patient. So we must know little questions here. Ventilators is the high pressure and low pressure alarm on there, and what would you do? I will move on. The word is next is some of the diseases, injuries, and what patient has. The problem is flail chest. What is the meaning flail chest is? Underneath, underline the word blunt chest trauma. There's a trauma to the chest. Patient is admitted with flail chest, meaning there's a chest trauma. And what does it can be accident, may result in fracture, maybe a rib fracture. So what is flail chest? Everyone should know chest trauma. That means there is a trauma. And what would patient would do when there is a trauma? The special breathing. All your questions, you're looking the kind of breathing. And what kind of patient is having breathing or respiration is called paradoxical respiration. What is the meaning paradoxical? When they're breathing in, inward movement. That means you can see the chest is going inward on inspiration. What is inspiration? Breathing in. So when patient is breathing in, you can see the chest is going inward. Are we clear? Underline the word outward movement during expiration. So sometime when they are asking you and they're saying patient is admitted with flail chest injury, what would you see the sign? Either they may use the word paradoxical or they may not have the word paradoxical. And when you are assessing, what would you see? Inward movement of the chest going in on aspiration. So when you are breathing in, you can see the chest is going inward, and when you're breathing out, you will see the chest is more like popping outward. Are we clear? Inward and outward. Inward when you're inspiration. Outward as you're moving out. So that's number one is on patient with flail chest. What is a flail chest? Chest trauma. There's a trauma and there is patient breathing is more. When you see them, they're breathing inward during inspiration, breathing out during expiration. Now I like it, number one, we already talked about. Number three, whenever patient has chest injury, they're going into what? The word is shock. Number 3. What is number 3 shock are? Hypotension, tachycardia, and tachypnea. So you can write down the word shock. So simple word is a bad injury to the chest and patient is having hard time to breathe, oxygenation, and what is patient is going here in the vital sign changes. And what does it? They're going in tachycardia and tachypnea, hypotension. Number 4, breathing. Breathing is affected. What kind of breathing? They are going shallow. They're having hard time to breathe. Now go back on number 2. Yes, they will have pain. There is an injury. They will have dyspnea and cyanosis, lack of oxygenation. So what are they having here? Lack of oxygenation. Now one word, everyone. How do we know? So many things we are learning, but first thing is flail chest word is chest trauma. What kind of breathing is important here? The chest is going inward in inspiration, outward during expiration, or they may use the word paradoxical respiration. Now patient is not getting oxygen. We all know dyspnea, cyanosis, pain is there, and patient is going in shock. What position do you do? All your breathing problem patient, you're going to put what? Fowler's position, so they can breathe better. So your position would be Fowler's. Yes, pain medication can be given, bed rest is given, but very important word is mechanical ventilator. Patient is not able to breathe their own, they're using the ventilator. Very important, we all should know the word is PEEP. And what is the word is PEEP here? The setting of the ventilator. What is the setting of the ventilator is PEEP. And what is the PEEP word is here? P means positive and expiratory pressure. So what pressure they're putting? The setting is PEEP. And the question can be, why do you put on ventilator? I want you to add there, everyone should know why. Is to improve oxygenation. What are we improving here? Oxygenation. So everyone write down the word is you are attaching the PEEP setting Y to improve oxygenation and open collapsed. Collapsed. And what is collapsed here is alveoli. A-L-V-E-O-L-I. Alveoli. What happened when patient is not breathing and they had injury? Alveoli is important because they are the one are collapsed and we have air sac inside the lung. And if those alveoli are closed, your air is not exchanging oxygen and CO2. So what do you, if there is a question, you are putting PEEP and also mechanical ventilator, and all your setting when patients are not breathing is the PEEP positive and expiratory pressure. And why? To improve, what are we improving? Oxygenation. And what are we opening here? Collapsed alveoli, and help them to keep them open. Are we clear? So they're opening and keeping them open, helping them to exchanging the air. Yes, you can give them bed rest, you can give pain medication, and patient may need oxygenation, you can add that. But everyone, just few wording is important. If you can memorize, you can come up with the good answers because we all know respiratory, the breathing problem. But one thing is important here is flail chest is what? Chest trauma. Everyone is okay? And what is the patient is having problem here is what kind of breathing? Paradoxical. And you can see sign the chest is going inward and on inspiration, outward on expiration. Patient is going into shock. Patient is having shallow respiration. Position you will go for is Fowler's position. And what would you give here? Mechanical ventilator. And what is the setting on mechanical ventilator is PEEP. And what is the word is on PEEP? Positive and expiratory pressure. I want everyone definitely to know the word PEEP. Everyone should know the word alveoli. Because what happened when they are collapsed? your air is not exchanging, your lungs are not functioning, and patient is not able to open their own, and they are not breathing in. So we are doing with the machine and mechanical ventilator, they're keeping them alveoli open, help them to exchange the oxygen and CO2. So those are important wording, and so we must know. Next wording is pulmonary contusion word. What is the word contusion? Is again, underline the word hemorrhage. Contusion means characterized by interstitial hemorrhage. Highlight the word hemorrhage. And what is the next word? Intra-alveoli. We said the word alveoli is inside the lungs. Again, alveoli. And what are they having? Contusion means injury, and what is it inside? They're bleeding. Are we clear? And where is the bleeding? Inside the alveoli or intra-alveolar hemorrhage resulting from pulmonary contusion. Whenever they're saying patient has pulmonary contusion, means intra-alveolar hemorrhage. Everyone is okay? Flail chest, injury. Contusion, bleeding. Are we okay? So where is the bleeding? Inside the lungs. And where? Intra-alveolar bleeding. Now you will go on data collection. What happened to the patient here? Number 1, dyspnea, we know. They cannot breathe. Number 3 is hemoptysis. When they're saying word contusion, what do they have here? Is hemoptysis. So as you see the word, remember the wording. Contusion means bleeding. And where is the bleeding? Alveolar, inside the lung. And what does the patient is doing? When they are coughing, they are spitting up hemoptysis. The blood is coming out. And what do you hear? Underline the word crackles. Now here you have crackles, there is a blood, and patient is having hemoptysis and wheezing. Patient is, you can hear, the patient is wheezing. Now what do you do intervention? So everyone is okay, contusion word is bleeding. Where is the bleeding is? Inside the lung, intra-alveolar. And what would be the main problem would be? Now patient would have dyspnea, they're not able to breathe. But remember the word is hemoptysis, crackles. And remember the word wheezing. So patient is having restlessness, lack of oxygen, they're bleeding. And what would you do is intervention. Maintain airway and ventilation by Fowler's position. And bed rest is good, limit activity is good, and again, mechanical ventilator with PEEP. Now, I want to repeat here, make sure we all know the wording. Flail chest means blunt injury. Everyone is okay? And what is the meaning? Contusion, bleeding. And where are they bleeding? And I said, highlight the word hemorrhage. And I said, where is the bleeding? Intra-alveolar bleeding. So inside they're bleeding, so when they're coughing, what are they taking out? Hemoptysis. And when you're hearing the lung sounds, what are we hearing? The crackles. And patient would have dyspnea and difficulty in breathing. Patient cannot breathe their own. We always position are going to be your Fowler's pain medication, oxygenation, and the next thing is we are going to use is the PEEP setting, and we already said why PEEP is to improve oxygenation. I think we'll take a break and then we'll continue 10 minutes break. Okay.